Good day, everyone. I am Ms. Valaida, the Director of Health Sciences Education, Ministry of Health, Guyana. So what I'm going to explain to you is what is currently done in Guyana and the action plan that was created in 2018. The second slide explains the action plan of Guyana background. I'm not going to spend too much time on that. I'm going to go into slide 3, which stipulates what we want to do. Guyana Action Plan actually focuses on diabetic care. Since the diabetes in Guyana has a system approach already, we would like not to recreate the wheel and use a system that exists for diabetes at regions that have a system. These regions will be explained and as we go down in slides 7, slides 10 to 16. First of all, I would like to acknowledge the research team, and thanks goes to the research team, but more specifically Mr. Hunt, the IPE-IPC project coordinator, the medic Syria Daniels from the Health Sciences of Education, Ministry of Health, for imparting knowledge, dedication, and support towards this whole initiative. So the first step in the action plan is to identify a research team in Guyana to work on the subject of IPE-IPC. This research team was created. First, one person was selected from the epidemiology department. We have another from the surveillance unit. We have one other person from the University of Guyana. 3 persons from the Health Sciences of Education. We have a research assistant on board. She is from the University of Guyana. And the chronic disease representative is here as well on the research team. So the second step is to build a consensus of what is IPE and IPC. Since it's a new concept and Guyana doesn't know about this, we plan to sensitize the regions of what it is. This was done on a whole day workshop in August of 2019, where Professor Gilbert and Jose visited the country. We had an opening of the IPE. We also actually had a visitation done at the regions selected to conduct the assessment. That's going to be explained later down in the slides below. The third step is to describe the demographics of the various hospitals or health centers, which are the targeted areas of the research. We have to identify either if it's an urban or rural area, the income status of the patients, the number of patients, the staff mix, and this staff mix is the health professionals, the different categories of health professionals involved or present within the hospital setting. The fourth step is to apply or actually assess with an assessment tool the existing systems within the hospital. So to determine the professional practice related to the management of diabetes care and whether there are interprofessional collaboration practices being done. Fifth step is to actually, when we do the assessment, to examine the gaps that exist and to carry out some educational activities with the health and social care professionals of the 4 hospitals selected. And this also involves the sharing the concept of IP and the importance of the development of ICP. Step 6 is initially we want to develop a curriculum, and this curriculum is going to stem from the assessment that was done. Curriculum in IPE for the Health Sciences Education Department of the Ministry of Health, the University of Guyana, and for it to be incorporated in the continuing medical education, the continuing medical nursing education within Guyana. So the targeted areas are the Georgetown Public Hospital. This is in the Region 4 district of Guyana. New Amsterdam Hospital. This is Region 6 district of Guyana. The Soddy Hospital. This is Region 2 of Guyana, and Linden Hospital Complex, which is Region 10 of Guyana. All of these areas have a systematic approach of treating diabetes or any other chronic illnesses, but more specifically, there is a more organized way for diabetes. So diabetes is actually used as a standard for any other diseases in terms of interprofessional education. This slide actually explains what is IPE. I'm not going to go into that. So the expected results is to improve the interprofessional collaboration practice amongst health and social care professionals in Guyana who work in the care of diabetes. So let me explain what was done of this year. So on February the 6th of 2020, the professors Susan Walsh, Dr. Memona Hasnin, and Dr. Valerie Gross from the University of Illinois at Chicago conducted a virtual IPE IPC talk shop with all tutors and coordinators of the health sciences education. A representative from the University of Guyana and Georgetown Public Hospital was present. 5 modules to the introduction of IPE ICP was sent to all persons mentioned above, but there was no comprehensive understanding of each module. Since we were not working with a budget, there were not enough available funds to accommodate the visits of the said professors above. Also, the COVID-19 pandemic arose, and so the group discussions were ceased. So it was only 5. It was 1 group discussion that was done out of 5. We visited the targeted areas just to enlighten them about IPE and IPC. We met with the leaders of the region Soddy Hospital, which are the regional health officer, Mr. Ranjeev Singh, and with Dr. Gray, who is the medical superintendent. The region welcomed the initiative, and they mentioned some of the fundamentals of IPE, IPC is done, but there is a limited amount of human resources at this hospital to conduct the actual IPE, IPC. They mentioned that there are about 60 diabetic patients that have chronic kidney dysfunction and who need dialysis. They, however, do not have a separate register of who are early or acute patients rather than late stage patients of diabetes. Dr. Gray was exposed to the international wound care training, and this training enlightened her about the interprofessional collaboration practice. So the system, they explained to us, the system involved in how the patient have access to healthcare is that they start off with level 1, which is they go to the health centers. The nurse interact with the patient first at these health centers, and triage is done. Then the patient sees the doctor. The doctor interviews the patients and prescribes the medicine. Since there is a high influx of patients, which is 80 plus patients per day at the clinic, there is not much educational sessions being done. If the patient encounter any complications, the doctor would then make a referral to the internal medicine clinic, which is the Saudi Regional Hospital. This is the hospital we would have visited. If the patient requires specialized treatment or care, they then need to be referred to a specialist to the GPHC hospital, and this is the referral hospital, which has the diabetic foot clinic. Dr. Gray had promised us to actually create a team for IPE, and the team would then be a trainer of trainers for the health centers. But however, there is still need to employ more health professionals to deal with this aspect. They also mentioned that the matron, she controls the nurse who works on a shift system, and the doctors work on an on-call system. The DFC clinic, which is a diabetic foot clinic, has 2 nurses, a diabetes educator, and the other is a trained wound care educator. There is also a nutritionist, and she comes to the hospital now and again, but she's not permanent there. Here is a picture of our discussions when we were interviewing Dr. Gray. This is a picture of the diabetic foot clinic at Saudi Hospital and the nurse that is there. This is the receptionist area. This is a chart that shows the various health centers in Region 2. So our visit to Region 10 of Guyana, Linden Hospital Complex, which is an attachment to Wismar and Kwekwani hospitals. So we met with the medical superintendent of Linden Hospital, with the RHO, Dr. Gregory Harris. The medical superintendent is Dr. London. An overview was done to both persons about what is our goal, our objective, and what is the IPE. They explained to us that there is some IPE, IPC being conducted. There is existing a dietitian. They're looking to improve custom relations within their organization, and they see this as a good fit. They have a physiotherapist and a social worker present in their facility. This is a much more advanced than study hospital, which was mentioned before. The medical superintendent asks for a list of objectives and the list of staff needed with the work plan and tentative dates for the whole aspect of IPE on before our second visit. The RHO, Dr. Harris, explains that there is a disconnect between the hospital and the health centers. The hospital is actually supervised by the CEO. The hospital is a semi-autonomous organization managed by the Ministry of Health, but it's not fully managed by the Ministry of Health. This institution was actually owned privately by the Linden Bauxite Company. The RHO is actually responsible for primary health care level 1 and 2. And there is, however, a communication barrier between the two systems, between the health centers and the hospitals. The feedback is not being done when patients goes to health center if they were to come from the hospital. So there is no background, there's no records there. So there is no feedback. So the doctor would need to start from scratch. Hence why we need IPE and the importance of IPE in Linden. The next visited area is the Region 4, Georgetown Public Hospital. We met with Dr. Samaru, who is the Assistant Dean, the CEO of the hospital, Mr. Brigadier, and the nursing directors, the medical registrar, Sandra Wins. An overview was done of IPE or IPC amongst these members present. Medical clinic, they explained that the medical clinic is running every day. GPC has a better scope of IPE since they have more health professionals present within the system. And this hospital can actually be used as a standard. They had a concern on how IPE would be implemented into the whole culture of the hospital setting. So it's going to be a drastic change for the cultural barriers and what we're accustomed to versus what is supposed to be done for IPE. And the whole goal is to improve patient care output. Conclusion. So at each visit, the leaders mentioned that IPE is done, but there is no standard use. They rely on their knowledge from the training they were exposed to. There is a need for more health professionals of different categories since this seems to be a limited amount with all regions visited. A work plan with objectives and tentative dates is to be sent to leaders so the assessment can initiate from the March 2021. For the training that was done with the University of Illinois should be more interactive, comprehensive, and rigorous since there was a lack of interest in reading modules given on the virtual platform. These are the references, and thank you very much for listening.